All right.
I think they have to give us a thumbs up.
Oh, really? I think no, then they say just go after the click.
Did they?
Yeah. Anyways, I'm here with Dr. Jennifer Sharma. Hello, Jen.
Hello.
My name is Benjamin Setzer. I'm a patient advocate. I've been living with Parkinson's for over 10 years now. Goddamn phone. I have an adaptive deep brain stimulator implanted almost 3 years ago. 2.5 years ago, I got the adaptive part of that turned on. But I'm here with Jennifer Sharma today. Hi, Jen. Can you please introduce yourself to the listeners first?
My name is Jennifer Sharma. I'm a movement disorder physician here at Queen's University. And should we first actually talk about how we met?
Yeah, why not?
Yeah, so I was doing my fellowship in Cincinnati, and
Under
I was...
who?
What?
Under who there?
Under Dr. Alberto Espe,
Right.
which we should plug in your book.
Yeah.
Absolutely.
Brain Fables.
Brain Fables.
Bye.
And so I think it was 2020 when we met.
No, it was 2019.
2019?
Yeah.
Well, that starts off really well. And you were coming to do work with Dr. Alberto Espe, and I was finishing up my fellowship over there. And we got to talking, and I don't think we've stopped talking since then.
What was the topic of our first, I remember on the grassy knoll there.
Yeah.
We were talking about, what was that?
It was death.
Yes,
it was death. The first thing we talked about was death. And that started, I think, a relatively beautiful friendship.
Yeah. Now, as a person living with Parkinson's, I think this is kind of a unique opportunity, a unique relationship as well, because she has obviously spent her whole life studying my disease in some ways. Now, Jen, I don't know how willing you are to talk about how many patients would you consider to be on the same level of friendship as you have with me?
I think you might be the only person I know at that level. Mm-hmm. There's lots of my patients that I consider to be very close, and I do get, and I think a lot of physicians do this, you get very personally invested in their stories. But of course, you don't live with the same day-to-day. But I think when you know somebody as a good friend, you get to hear about every trial and tribulation. You get to go through the ups and downs. You get the texts about what is happening. And I think that's a very different emotional connection. Because when you see a patient on a regular basis through clinic, you're going to see them, say, every 3 months or every 6 months. But, there's not the same, hey, I'm going to text you at, 2 o'clock at night or something like that to say that this is what happened. Yeah. It's very different.
So what's that journey been like for you, watching me? You've known me for almost 5 years now.
Yeah.
I've obviously had my own series of ups and downs. I got DBS along the way. Can you try and summarize what's that experience been like for you, watching me as a patient going through something that you've been studying most of your life as well?
It's there's something to know. It's one thing to know something theoretically, and or academically, and it's one thing to study it, but to see that play out on a day-to-day basis with you, to see. I think the first time that I met you, when you didn't have anything, you were playing basketball. You were very active.
I still had Parkinson's though.
You still had Parkinson's, but you were a different man.
Yeah.
And to kind of watch your changes, the progression, the addition of a deep brain stimulation, to see you kind of go through that process from a friend level. There are times where I've stopped being a physician, and you just start worrying about you, like, hey, this is what's happening. I think it does lose some of the logical side of me. Is not always turned on when it comes to you. It's just like, hey, I need you to be better.
Yeah.
But it's not necessarily that can happen instantaneously.
Now, as someone who's now 10 years into my disease, how would you summarize how I'm doing right now?
So I think that comes back to when I first saw you, you were very active. And some of your gait issues, the speech issues, none of that was there. We were still able to see some of the mild freezing, I think, initially. But I think if somebody saw you on an everyday basis, you had, some of the tremor, some of the classic symptoms, but it was relatively masked. But of course, you were living your day-to-day with that. But overall, not everyone would have been able to tell that you had Parkinson's at that time. When you were on your on state, right? Very different. You were starting the fluctuation cycle. but I don't think immediately someone would have been able to tell you have Parkinson's.
Have you seen me at what you think, or what would you describe as my worst state that you've seen me in? When were you the most worried about me?
This past year, like honestly, it's been this past year. The one thing that you pride yourself on a lot, and I think you admit that, it's your mind and your ability to speak. And when you have lost some of your words, I mean, you should also talk about that a little bit. I think when you've lost that, seeing you struggle through that might have been, even more so than the gate freezing or anything like that. That's who you are as a person. You're a person that communicates. You're a person that talks, and you need that to be like an essential part of you. So when DBS came on, initially you were great, but then in the past year, when you've started to have some of the loss of speech, I think that's when I've been the most worried about you.
Would you describe those as like loss of cognition as well? Like, would you say I have a cognitive deficit as a result of?
I don't know if I mean, that goes into some of the things that happened post DBS for you. That's where the cognitive and psychiatrically things have come into play. But I wouldn't describe when you've lost some of your speech as a cognitive thing, because I think you've always known what you want to say. It's the ability to get those words out.
Yeah.
So I think that's slightly different than to say that your cognition was affected. I would say that your cognition was affected at different times during your DBS journey.
Yeah, but it's hard because for me it's been very much about the rate of getting my words out into the public.
Yeah.
Making sure that I'm speaking as clearly as I possibly can.
Yeah.
But then it's about, sometimes I feel it's almost like a muscle thing. Like I can't even like intonate some words properly.
Yeah.
My mouth is too slow in being able to jump from one word to the next.
Yeah.
Rather than actually being a matter of cognition. Like it's not
I agree.
I've forgotten any words.
Yeah.
But it's a matter of like being able to retrieve them and having them as readily accessible as before.
So do you think a retrieval aspect has also been affected recently?
Yeah.
Yeah.
I would say that's my primary deficit right now, actually.
Yeah.
Then like this tremor, but whatever.
Yeah.
And like there's some mild gait issues as well, but
Yeah.
they're relatively under control right now anyway.
The
However, I have been falling from time to time as well.
Yeah.
That is probably more worrisome for like my parents than I think it is for me, but maybe it should be more worrisome for me.
I think so. I think, and if we can share this,
Yeah.
I mean, yesterday when you were just trying to show what happens to you on a day-to-day basis, I think that's the first time I've seen you actually fall spontaneously backwards. Of course, we know that can happen, but watching that happen, it has changed.
Now, in your opinion, because research might not be your primary focus right now.
Yeah.
You've interacted with the research community before.
Yeah.
And you've obviously like Susan here at Queen's U a little bit. I'm wondering, what do you think that the research community could gain from having more relationships and interactions like this one? Like what me and you have?
I think there is something to. That's a good question. There is something to knowing an individual personally. The stakes become higher. But that's not to say that individuals that work in PD research or any other type of research don't take their research very personally and don't really care about what they're doing. But knowing what is important to patients and addressing that, as opposed to all the various things that we do, and I'm sure you've talked about the various research that is out there that sometimes does not amount to anything. Sometimes it's merely for the sake of a publication. And that gets into all sorts of things about academia and whatnot, and we probably don't need to go into all that. But knowing patients, what they care about, what they're able to do, it needs to be a two-way street, because clinicians, researchers cannot do this research without patient input.
But do you feel like...
And having more trust between that relationship, I think, is so incredibly important. And I think you should actually talk about your relationships with the physicians that you've known, because I think I don't know many other patients that have had the relationships with their neurologist, especially with Dr. Fasano. That's a incredibly unique relationship you've developed there.
It is, but it's one that I wonder, like, how applicable is it for other patients?
I
Yeah,
don't think very applicable.
Yeah. So I wonder, like, how much benefit there is to talking about it, other than, like, me just getting my own thoughts out into the world. Because, like, we're obviously each, like, walking our own path here.
Yeah.
But I've spent, like, I've taken up so much of my own time, my own resources, trying to get to know my disease, getting to know this community that's surrounding the disease as well. It's something that I wouldn't expect other patients to be able to do. But I do know, I should say, though, that I have gotten to know recently some other patients who I feel like want to walk in my shoes. They want the kind of access that I have.
And I think
And
that's
feel like,
amazing.
Yeah, honestly, I wish I could give them the kind of access that I do have right now. I know, like, some patients that are struggling, like, far off corners of the world.
Yeah.
They can't access the kind of specialists that I can access. They wish that they could.
And I think you really have become a voice for the patient community, right? And you're able to translate some of the things between patients and physicians, and not just your average physician, but people at the level of, say, Dr. Fasano and Dr. Espe and others.
Yeah.
So I think that's to be really, really commended.
Thank you. Thank you, Jen.
You're amazing.
But that does kind of, in a roundabout way, bring me around to another topic I want to talk about a little bit more in depth with you. That is the MAID program that we have here in Canada and Toronto.
Death, our first conversation.
Yes. What do you think about death? No.
I'm for it.
Kill them all. No. At what, like, have you thought about at which point would not necessarily me, but patients in general, at what point in their journey should they start to seriously consider this topic? And, like, at what point should they start to approach their neurologist about this?
Yeah.
Like, has anyone ever broached this subject with you before?
When it's come to, over here at Queen's, you're not going to find neurologists that purely do one thing. So I also do a lot of general neurology too. And occasionally I do see ALS patients. We're very lucky here to have our other neuromuscular specialists that deal with deal with diseases like that more so. But I've seen ALS patients. I've seen frontotemporal dementia patients. Huntington's disease also, I've dealt with a lot of MAID and facilitated the process for patients that want that. But since I've been, let's say, a real doctor after fellowship for the past 2 years, I haven't had many PD patients approach me. And
about MAID specifically?
About MAID specifically. I think it's always, it is something I struggle with to know when to bring up, because I want to make sure that my patients know that if I bring it up, I'm not saying, okay, you know, this is the point where you're at, and I think this is what should happen.
Die.
Yeah, and I would never want that for my patients. But at the same time, I feel I want my patients to know that if they ever wanted to, if they ever chose to go down that route, that it is an option. So that is a hard part of, when do you bring this up as a possible option for certain individuals, or should we bring it up for everybody across the board at your first visit or second visit? And I'm not sure even I agree with that. So I really do struggle with when to bring this up. I do. And but if patients come to me, then the situation is much easier to say, hey, I'm advocating on behalf of the patient. My goal as a physician is to make sure that I'm decreasing suffering. Like, at the end of the day, I think that's not just as a physician, that's what we're trying to do as human beings across the board. You're trying to decrease suffering in the world. And if I can do that in some small way, absolutely. But the concept of death, the concept of facilitated death, I think it's very hard for people to wrap their minds around. But I also want people to know that that's an option, because at the end of the day, you need to advocate for, what's that term now? Patient. Yourself, but patient independence. Empowerment. Yeah. So it is hard. It is hard to know when to bring it up.
When should we not bring it up with our doctors? Like, is there a point at which, like, it just becomes like an obscene fetish in some ways?
Do you think do you think there are certain physicians, or do you think there are certain diseases that we should never bring it up in?
Yeah.
So, I mean, this is like a quite debated area, right? It continues to be debated. And what we were talking about with, what we were talking earlier today is the idea of capacity. I think as long as you have capacity, as long as you're fully informed about the risks, the benefits, the expected progression of your disease, you're fully informed to make that decision, absolutely. But then when it comes into areas such as cognitive impairment, can you make a decision for your future self, knowing that that individual at that time
Will be a different person.
might be a different person and might want something different.
Yeah.
What supersedes what?
Yeah.
Actually, not what, who supersedes who?
Yeah.
And then we were also just earlier talking about autism, intellectual disability. You know, it's a very gray area of at what point does a person not have capacity to make decisions for themselves? And here in Canada, at least, you need to have capacity. You need to have the mental capacity to make that decision for yourself before you are allowed to undergo MAID. But obviously in the Netherlands and even in some areas, there have been a few cases here in Canada as well where patients have developed dementia, but the prior self at a previous moment in the past, they had determined that if it ever got down to that point, they would not. And there's also degrees of cognitive impairment.
Yeah.
So it does not simply mean you ever have cognitive impairment, you're done. No, so there's also degrees of capacity within that. I think it's just, this is where you need like a true neuroethicist to weigh in on this, and people debate this ad nauseum.
All right, well, that brings me somehow around to my last kind of topic I wanted to talk about with you. And that's also a very self-serving one in some ways. But so I'm very well connected to the tech community and to tech entrepreneurs, people in San Francisco, but also in Toronto, Boston, all around the world, who are all thinking about, like, what should I be working on? What should I be developing to help more people? What can I do to limit suffering in the world through technology? And I guess the question is, at what point, or what kind of technologies do you think people should be working on, for one? But two, are technologies going to be the I don't want to say panacea, but like
The answer?
Are they, like, at what point will technology fail us? Like, at what point will technology be a solution that we pump up too much, and too many people will be looking for technology rather than other solutions that might be available to them? I don't know if that makes any sense, but
kind of.
Yeah.
So
Maybe
the question is, what
first.
is the role of technology in, say, neurodegenerative diseases?
Yeah.
Right?
Today.
Today.
And what would you like them to be in the future?
I mean, I would love a Star Trek world where you're put into a little tube and it diagnoses you and it fixes everything. That's sort of this magical thinking, right? But we're obviously not there. And we were actually just chatting yesterday about having you talk to various experts in Parkinson's and neurodegenerative diseases around the world to see what they imagine the future to be. So I think from a technology perspective, that would be fantastic to see.
Like a full brain scan of my substantia nigra that shows like every neuron.
Oh, it would be incredible, and it fine tunes exactly what is needed.
Yeah.
It identifies what the exact etiology for your Parkinson's is at that moment, whether that's an environmental, whether that's a viral, whether that's genetic, whatever it may be, right? And it fixes that one thing. That would be, like I said, that's Star Trek.
Yeah.
That's Star Trek at this time. Or Elysium also had that too, which is a really good movie. But at the question
today, what should people be working on? What do you think is the next? What kind of tool would you like at your disposal in your clinic that might help you do a better job? Like, we have a lot of technologies that can be used to track patients all around the world.
Yeah.
What kind of information would you like to be able to see at a glance?
So that's what Rune Labs, what you're at, is working on. I think having an abbreviated summary, because the one thing that we struggle with here in Canada is perhaps time with each of our patients. And perhaps not just here in Canada. I think this is a global thing. How much time can we spend with patients? Because when it comes to things like Parkinson's, As you know, this is a multi-systemic disease. It's not, if it was simply as, hey, you have a tremor, you have gait difficulties, that's it, we're good. We wouldn't need any of this other stuff. But when it comes down to the non-motor symptoms, how do we manage every single symptom that can take place? Having an abbreviated summary of everything from the last time that I saw you to today.
What about like handling that in-between space where patients are out in the world, but you're still able to kind of track them in some way and see how they're doing? Would that be something that would interest you?
That would be fantastic, but again, that requires time. If you think about the number of patients each physician is following, and you're following
By
them
time,
each...
you mean like time they're being compensated to do that as well?
Oh, not necessarily compensation. It's...
But I mean, that has
because
to be
you're
part of it, because otherwise people are not going to be incentivized to even look at those charts, right? Like we can create them all.
Partially, but every single day that I'm... Say that I saw a patient 6 months ago, and I have a 6-month appointment coming up with that patient. Say that I was tracking that patient every 1 month between that time. That 1 month, every time I'm tracking, I'm also seeing other patients that I'm going to see 6 months from now. So you can see that initial 6-month visit now becomes 6 visits.
Yeah.
But
And
if
then you can also
everything could be abbreviated into like 3-4 minutes, like, hey, I have everything 3-4 minutes and I can get all the prescriptions out, I can get all, then great, that would be fantastic. Then you can follow patients more often, and and that would be great if you could do it in a very short amount of time. But I think to understand about PD, and this is where the summary really comes into play, you would have to track hundreds of patients every day.
What about for those patients that are further afield? Like we're here in Kingston. Kingston covers up to Moose Jaw, which is like hundreds of kilometers to the north.
Yeah.
So enabling a system where they don't have to come in to see you necessarily, but you don't have to necessarily go to see them, where you can have some kind of like...
This is where telemedicine would be really useful. So I think the next time you do this, I think Dr. Stuart Reed over here, he has gone up to Moose Factory for I think multiple years, and he's also a movement disorder specialist over here.
By the way, for those wondering, Moose Factory is not a factory where they make mooses. It's a town in northern Ontario.
A joke, Canada joke. Yeah, so Dr. Stuart Reed over here, he's a fantastic headache specialist and movement disorder specialist, but he's been doing this for multiple years. And talking to him about the difficulties of helping our northern community out would be very useful. Would telemedicine help? Absolutely. But you also, it's a whole community issue, right? You need to make sure you get them. The resources is not simply do you have a neurologist that can prescribe this one medication. It's getting people to appointments. It's making sure they have the prescriptions there, making sure everyone is followed appropriately, making sure physiotherapy, your speech therapy, your swallowing people. I mean, it's, like I said, multi-systemic. You need all of those resources in place to give someone proper care. Because when it comes down to it, I'm very humbled being in movement disorders and in neurology, because I think we're great at some things, but it's really our colleagues, it's our physiotherapists and occupational therapists that do so much of the work when it comes to these things, right? They're the ones that allow you to live. They're the ones that make you stronger. I feel like sometimes as doctors, we kind of come in and we say, hey, tweak this, tweak that, and we send them on your way. But who are the people that are there day to day making you stronger? It's those guys. And I cannot applaud them enough in what they do. So it's those things that would be really great. We need more primary care doctors. It's a systemic issue.
We also need more neurologists.
Definitely, but we also need. I think right now, here in Canada, the biggest issue is primary care.
Yeah. Well, on that note, Jen, thank you for coming. Thank you to this makeshift studio.
Amazing.
Here. Yeah.
Thank you, Queens.
Any final words for the audience?
No, I'm really excited that you're doing this, and I'm really glad that the patient advocacy community has someone like you. We really do need to bridge the gap between patients and clinicians, and I'm really happy to have you as a friend, because it's opened my eyes to quite a lot of things. But also I truly have learned a lot from you. We have different specialties for sure, but I've learned quite a lot from you. I mean, we disagree on a few things too, but that's been part of the fun of everything. So no, thank you for having me on this.
Well, thank you. Cut.